So I think we'll get started. Welcome everyone. I'm Kathy Scrimshaw. I'm a family doctor down in Pincher Creek area in Southern Alberta, and I'm the medical director of the CMN. This is our last in our ECHO series. And I just want to welcome you all tonight as people get let in. And if we can go to the next slide. I just want to acknowledge today that what we call Alberta is the traditional and the present day territory of many peoples presently subject to the treaties 6, 7, and 8. I would like to acknowledge and thank the many First Nation, Métis, and Inuit who have lived in and cared for these lands for the many generations. I make this acknowledgement as an act of reconciliation and of gratitude to those whose territory we reside, work, or are visiting. I'm speaking to you from the traditional territory of the Blackfoot Confederacy down in Southern Alberta as well. Our session agenda, as much as all of them have been, so we'll be doing our disclosures, housekeeping, and introducing the team. We will have a speaker presentation on ketamine and pain, and then we have Dr. Maria Pelova, and a team from Yellowknife, Northwest Territories, with a very interesting and complex case that we'll be discussing. So hang on, and we'll go to the next slide. And so I'm Kathy Scrimshaw, and I work part-time for the Alberta College of Family Physicians, and I'm also a part-time employee of the Alberta Health Services Indigenous Wellness Corps. And my colleagues Salam and Maya are also full-time employees of the ACFP. Next slide. This program does receive financial support from Health Canada through the Substance Use and Addiction Program in the form of an educational contribution, and receives in-kind support from the Alberta College of Family Physicians in the form of administrative and technical support. Also, our speaker and hub team member has received an honorarium from the Alberta College of Family Physicians for this presentation. And there's been considerable process in mitigating potential bias. I'm not going to read this out, but our scientific planning committee, as well as our staff and myself, do go through all the evidence that is presented, and also with the ECHO, with community and hub team evidence and resources, we do our best to ensure that they're evidence-based, our best practice. Next slide. And so to capture your attendance, if you can click on the survey link in the chat log, you can use the raise hand feature, but we'd really like you to engage in the conversation and verbally ask your questions. We have a dedicated time for the Q&A at the end of the didactic presentation, and we can collect in the chat your questions. And during the case presentation, there's lots of time to ask clarifying questions and share information. And the evaluation is super important. So we'll post that in the chat near the end of the session, and we'll also send you a nagging email to fill it out if you can. So it's very important for us to understand how effective ECHO is. And so I know many of you have joined ECHO sessions before, but if you can turn the cameras on and try to engage in those conversations, and definitely ask your questions verbally, that would be great. And this is really an all teach, all learn philosophy. So we all have something to contribute and to understand through this. So I think we've gone through our support team. I will be your facilitator. And today we have Dr. Ted Finley, Dr. Laurie Montgomery will be late, Kelly Shinkaruk, who is our speaker, Amy Niles, Julie Min, and Dr. Sasha Mala. These guys are ready to guide us through this case as well. And they also do learn from us generalists out in the front lines. So please feel free to share your relevant tools and your resources. And with no further ado, I think I'll introduce Kelly. So Kelly is one of our chronic pain hub team. She has done both an anesthesiology residency and a chronic pain fellowship at the University of Ottawa. She works both at the Foothills Medical Center and the Rocky View General Hospital in Calgary, providing general anesthesia services. She also does acute pain, interventional palliative pain management. And while working at the Calgary Chronic Pain Center, she offers a combination of interventional and non-interventional therapeutic approaches. In addition to her clinical practice, she's completed a master's degree in medical education with a focus on interprofessional collaboration and education, and has functioned as the Pain Medical Residency Program Director since 2015. She sits on the Royal College Specialty Committee for Pain Medicine. And so she has been providing mentorship to the primary care network pain programs in community, and she likes collaborating with her colleagues in primary care, as well as her surgical specialists and palliative care. She looks forward to expanding clinical support and education through the ECHO program. And now we'll turn it over to you, Kelly.
Oh man, every time that bio comes up, I'm like, oh, and meanwhile, I'll have to change some of those things. But thank you for the introduction. I'm just going to share my slides. So as annoying as it is, I'm just going to ask and make sure that it looks, everybody can see my slides. They look okay, clear. And I'm going to go right ahead and jump into this because 10 minutes goes by so quickly. So thank you so much for joining us for the last Chronic Pain Echo for 2022. I'm not sure if what is to come in 2023, but my name is Kelly. I've really enjoyed working with all of you for the last almost 12 sessions. I think I just missed one or maybe two. After talking to Kathy, we had originally had another plan for this session, but because there have been a lot of questions about ketamine, particularly as there's been an increase in interest for depression, we thought it might be interesting to review the chronic pain side of ketamine. So I am going to go ahead and move forward if I can. Disclosure statement, I've received some honoraria. I do have a clinic affiliation. So I am a chronic pain lead at a clinic that provides ketamine. I hope that that doesn't influence this discussion. I've included a lot of different elements about ketamine. I am going to discuss off-label uses of ketamine, but I think that that will be kind of clear. Learning objectives wise, we're going to review very briefly the pharmacology of ketamine, discuss indications, contraindications, routes of administration, and dosing. And I'm going to provide a very brief overview of the recent literature on ketamine use for chronic pain management. So ketamine was developed in the 1960s. It's classified as a dissociative anesthetic, and it is a cousin of phencyclidine. So fortunately for ketamine, it has fewer side effects such as emergence delirium, which is why it was so interesting as an anesthetic agent. It exists as a racemic mixture of an S and an and an R enantiomer. The S enantiomer is more potent and has a higher binding affinity than the R enantiomer. So furthermore, ketamine metabolites, including norketamine, are active at some of the target receptors. It's metabolized hepatically through the P450 enzymes. So as we all know, that can play a role in how people do respond and what kind of dosing strategies we need to use. Furthermore, a recent intranasal spray called S-ketamine or Spravato has come to market. It's for treatment of refractory major depression, and there's no equivalent for pain management at this point in time. It has been used in acute care. It's considered a safe and effective anesthetic agent, and it has analgesic properties, which is the reason we're talking about it today. But this is interesting because from an anesthesia standpoint, it's different than all other anesthetic induction agents. So in fact, in some cases, we can use it as a replacement for opioids in certain scenarios. And there's been a growing interest in this given concerns around the opioid epidemic in North America and trying to minimize or prevent exposure to opioids in a perioperative setting. One of ketamine's effects, unfortunately, it's considered a negative side effect, is its psychotomimetic effects. So many people would be familiar with ketamine as a party drug or as a street drug, often leading to dysphoric episodes. This has limited ketamine's use because of the intolerable dysphoria. And in patients that are unprepared for that effect, it can lead to traumatic experiences. Interestingly, however, and I don't have time to get into all the mood disorder literature, but the psychotomimetic effects are actually considered to be a large part of treatment. So ketamine has many mechanisms of action. This is what we would consider, say, a promiscuous drug because it works on a number of receptors. It exerts its analgesic effects primarily through actions on the NMDA receptor as an antagonist. So this activity is believed to be responsible for decreasing the incidence of central sensitization, opioid-induced hyperalgesia, and decreasing symptoms like allodynia, hyperalgesia, and neuropathic itching. NMDA receptors are present throughout the periphery, so they're present in the central nervous system, but also throughout the periphery, and they're likely responsible for some elements of peripheral allodynia, hyperalgesia, and itching. By blocking these receptors locally, patients may be able to minimize or avoid systemic analgesics. So that's where we will talk a bit about ketamine as a topical agent. In addition to the NMDA receptor activity, ketamine also has effects at the mu and kappa opioid receptors, and it's thought that this is where it can delay desensitization and improve resensitization of the receptors, thereby decreasing opioid-induced hyperalgesia. I will say that there haven't been any significant studies looking at the use of ketamine in addiction. I mean, there's always that question. So if people can be given something that will decrease or minimize or reverse opioid-induced hyperalgesia, there's always this question whether it can be used for detox. And unfortunately, it hasn't really been extensively studied in that way. Furthermore, it acts on GABA, acetylcholine, and dopamine receptors. It blocks the HCN1 pacemaker channels, and probably of great interest is its effect on the toll-like receptor 4 and nitric oxide synthase targets. So both reduce pro-inflammatory cytokines and inflammation markers, and peripheral antinociception effect is probably due to the neuronal nitric oxide synthase activity. This is just another diagram demonstrating how these effects on the different channels and different neuromodulation effect. Just as a bit more reference to inflammation and the fact that ketamine is an anti-inflammatory, but ketamine acts interestingly on the inflammatory pathways. It can decrease exaggerated systemic inflammation, but it doesn't interfere with essential healing processes. So it works as an anti-inflammatory without changing immune activation, which makes it interesting as in comparison to an NSAID or to something like acetylsalicylic acid. So it is an anti-pro-inflammatory agent rather than an immunosuppressant. And it's thought that this is the reason why it has antidepressant qualities, as well as one of the reasons and explanations for its analgesic properties. Now, moving on to discussion of routes of administration, indications, and contraindications. This article was published in Minerva Anesthesiologica in 2015 and provides an excellent review. So if there's an article that you want to read for a lot more of this discussion, I would advise and recommend this article. In the article, it talks about indications for topical ketamine as being in patients with fairly localized or well-demarcated pain distribution. So those with things like postherpetic neuralgia, diabetic peripheral neuropathy, and chemotherapy-induced neuropathic pain. I've also used it in patients that have post-surgical pain syndromes where we think that there is a neuroma involved. And then other localized pain syndromes like CRPS, pelvic pain, specifically things like vulvodynia and erythromelalgia. And finally, neuropathic itching. Interestingly, there are very few contraindications to topical ketamine because there's very little systemic uptake. So when studies have been done looking at the plasma concentration of ketamine, they find no ketamine in the circulation when used topically. So it's thought that it's likely metabolized in the periphery, or it's so little is taken up into the system that it's not contraindicated in some of the other in the other diseases that it's contraindicated for other routes of administration. Dose finding studies haven't been done, and most of the studies include co-analgesics in the compound. They include differing frequency of administration, differing topical bases. So it's hard to kind of compare apples to apples, but I think an evidence-informed approach would suggest that ketamine concentrations up to 20%. I've never used 20% ketamine, and it's usually because I'm mixing it with other agents. It can be applied to affected areas 3 times a day. In my practice, that's what I do. I think that most compounding pharmacies are going to be very helpful and will guide optimal formulation. So if you're curious about what you can do with topical compounds, I'd reach out to your local pharmacy that will do the compounds. The next article I just wanted to briefly present is this is published 2021, and this is looking at studies including oral, intranasal, intravenous, and even neuraxial administration of ketamine. So this study didn't look at topical specifically. So this is kind of all of the other routes of administration. Given a large degree of first pass metabolism, intravenous is still considered to be the most reliable because its bioavailability is 100%. Whereas with oral administration, bioavailability is considered to be between 16 and 25%. And intranasal is considered to be around 30%. So dosing for PO administration and intranasal administration is much higher. This literature suggests that it's around 2 milligrams per kilogram, given the bioavailability, while dosing for IV is around 0.35 milligrams per kilogram, and then is often higher, but it is given over longer periods of time. We'll talk about a couple of seminal articles in a second. Indications for IV ketamine, which you would also consider for PO or intranasal, but we'll kind of talk about the reasons why we wouldn't do that very frequently or in typical situations. Indications would be, again, intractable pain conditions like CRPS, phantom limb pain, spinal cord injury related pain. There have been studies looking at cluster headaches, central sensitization pain, and I put a question mark next to opioid-induced hyperalgesia, and that's because I have certainly used it for a couple of clients that have a history of very high opioid requirements and then subsequent increased pain. And sometimes we'll use ketamine to see if we can decrease some of their opioid requirements. Contraindications, so in this setting where you are giving it and it is being absorbed systemically, would be uncontrolled hypertension, significant cardiovascular disease, hepatic and renal disease, mass occupying brain lesions, and history of psychosis. So now I just, as mentioned, I wanted to review just a couple of the sort of seminal articles on ketamine and CRPS. This is where it has been studied to a much greater extent. So Signermans is a Dutch anesthesiologist and intensivist, and he conducted doctoral research on CRPS and ketamine, leading to his dissertation publication. And it's largely viewed as the best study, the most stringent study looking at ketamine therapy for CRPS. It included 86 patients with CRPS type 1, and his protocol included continuous ketamine infusions lasting for 100 hours. So these patients were admitted to the hospital for days, and it did demonstrate positive benefits lasting for up to 12 weeks post-infusion. The other thing that I think is really interesting in this study is there was actually a crossover arm. So patients that had received placebo in the first arm, so you can see here, these were patients receiving placebo. They had very little change in their pain from baseline versus those receiving ketamine. And up to 12 weeks out, they were still, this isn't really significant, but they were still lower than baseline. But then there was a second arm where those who had received placebo were then offered ketamine. But when they were offered ketamine in their second arm, they were aware of it. So it was an open study, and they actually had a much greater response in the open study. Sorry, I was kind of pointing to the wrong line. So this is the open study, and you can see that their pain response was even greater. So I always think that this is really interesting because I feel like it really points to an element of the placebo effect and the power of patients knowing what they're receiving. This study is a little bit more pragmatic. So as you can imagine, admitting a person to the hospital for days on end to receive these infusions is really cost ineffective. It's not going to be manageable for most people. But this more recent study by Kirkpatrick and his team was using a much more pragmatic approach. And that's by using ketamine on an outpatient basis. So patients would come in for 4 days in a row, and they'd be receiving sort of stacked amounts of ketamine. And again, I don't have a nice slide showing what the response was, but these patients also had significant pain response. So at least in complex regional pain syndrome, we do feel that there is potentially a role for ketamine. Of course, this would be in addition to all of the other multidisciplinary things that we would be doing with patients with CRPS. There were a lot of studies done, and there have been a lot of studies done going back even to the 1960s with ketamine and headache. A lot of this investigation, a lot of this research has used emergency department administration of single infusions for acute headache episodes. And so unfortunately, that has led to rather poor evidence to support its use in that setting. But there has been a growing body of literature looking at ketamine lidocaine refractory chronic migraines, as well as cluster headaches with positive responses. Those protocols would generally be in the range of receiving intermittent intravenous infusions, usually once every 1 to 2 weeks for a stack. And then patients that have remission of their headaches would then go on to have potential for maintenance intravenous infusions, usually every 3 or 4 months. So this led to an interest in publishing consensus guidelines. And in 2018, ASRA, so the American Society for Regional Anesthesia and Pain Medicine, and the American Society of Anesthesiologists co-published these consensus guidelines. And really their overall conclusion was that there was moderate evidence to support higher dosages of ketamine over longer time periods and more frequent administration for chronic pain. So they go on to indicate that it's reasonable to start dosing with a single outpatient infusion at a minimum dose of 80 milligrams lasting more than 2 hours, and then to reassess before initiating further treatments. They also talk about how it's really only been studied for a very small number of indications, specifically CRPS, post-stroke pain, spinal cord injury pain, and phantom limb pain, as well as cluster headaches. So, but they talk about how all of these studies are very low numbers, and the protocols have been challenging, to say the least. So the biggest issue, I think, is that who is going to administer this? Where is it going to be administered? How are we going to select patients? It's really this is really not something that we're going to be able to do for every patient. And until those issues are resolved, I think the most important route for people in the community is going to be topical application. And I think that, that will be very acceptable for many patients just to try. Ketamine isn't a panacea. This is really my last slide. So the population we're treating, whether for mood disorder or for chronic pain, I didn't have time to go into mood disorder literature, but it's generally considered to be highly refractory groups of patients. There are going to be people that are responders, and there are going to be many more patients that aren't responders. The complexity is that even in comparing the same diagnosis like CRPS, some patients are responders and some aren't. There's probably an element of the liver enzymes and how they're functioning, as well as a variety of other contributing factors. So I do wonder if there would be a role in introducing this to a greater number of patients, just to see if it will help to offset some of the concerns that we see with central sensitization, with opioid-induced hyperalgesia. And I will be curious to see what happens as we introduce more protocols at places like the Chronic Pain Center, as well as there is at least one center in Edmonton that offers ketamine. It is a safe alternative to many other analgesics. However, because of the limited bioavailability when taken orally, as well as potential complications associated with a long-term use, including ketamine cystitis, hepatotoxicity, cardiovascular complications, as well as a big question mark for addiction, which isn't largely reported in the literature, but there's always the question whether there is addiction potential. The reasons that we're interested in using ketamine will still need to be kind of offset by how we will administer it. So on that note, I hope that was pretty close to 10 minutes. I don't even have a clue, but does anyone have any questions? I will stop sharing. Was I pretty close to 10 minutes?
You were good.
Oh,
So, any questions? I have my usual question, is this covered?
so I mean, I guess at the end of the day, the question is where patients are accessing it. So there isn't an SOMB code. So usually if people are accessing it, it's through programs like the Chronic Pain Center. And unfortunately, we don't have like an arm that's like specifically just for ketamine. We're getting, because of the interest in it in the mood disorder setting, now that people are aware of its existence, we're getting a lot more questions about it. And I know that Magali here at the Pain Center is, kind of, it can be a bit frustrating because we just don't have an arm specifically for ketamine, but there are patients that are within our program that have been able to access it. I do have a few patients that get ketamine intermittently that have just gotten through to us through those avenues. But unfortunately, there are no community kind of based programs that will offer it under a public health funding framework. That's why I said at this point in time, it's still going to be largely use of topical applications. And I think, certainly reach out to one of us. I'm sure that between Ted, Lori, Julie, myself, there are a few of us that would be happy to talk about, do phone consultations with whether it would be appropriate to do a trial with oral or intranasal, recognizing that there can be potential long-term complications, but we have had patients in our program that have ended up with intranasal or oral ketamine. It's just the, bioavailability is a limitation. So
Any
we
questions?
are hopeful that eventually it will be added to the SOMB. I will say that, and I do know, I work at a ketamine clinic. I know that is a potential conflict here, but the people who run the clinic are constantly having meetings with the Minister of Health, and it's definitely within our mandate to push for coverage. I don't think that anybody wants to keep it as something that only people with a lot of money can afford to have done. So.
Great. And we have a question. Ash, do you want to ask?
Hi, thank you for this fantastic presentation. I'm a palliative care physician, and we deal with a lot of pain that are very difficult to manage in the community. I was wondering if you can comment more on intranasal and PO, what dosing, and when is it that you consider it?
Yeah, so the patients that I have used it, and there are really just probably a handful in my practice over the past 12 years. Usually what I would do is either a 50 milligram intranasal spray, or I have seen 150 milligrams. So it's in the literature, it kind of comments on sort of 2 milligrams per kilogram for a PO dose. So kind of taking the average adult male, 75 milligrams or so, 150 milligrams PO, and you'd be using it in the range of 3 times a day. The patients that I would consider using it might be patients that have had exposure through intravenous routes, either through a program like this, or in your case, you might have patients that have been through the hospital setting and they've received it in acute care. And in those cases, if they have had response, but the response is limited or of limited duration, then it may be worth considering. Does that answer your question?
Thank you. May I ask one more question?
Only if you fight Tina. I'm just kidding. You don't have to fight Tina.
Can I ask if you ever use that in combination with methadone?
Not specifically. I don't think I've had any patients where I've kind of specifically used methadone and ketamine. But I mean, if you're asking about the NMDA receptor antagonism element, I mean, methadone is also an NMDA receptor antagonist. So I'm not sure what the additive benefit is. I've never read an article or a paper that looked at those as a combination versus as a comparison. But it would be interesting. I mean, ketamine has all these other elements, like the anti-inflammatory elements that methadone wouldn't have. But yeah, that's a good question. I'm not sure if anybody else has heard of anything like that. I'm also happy to defer to other smart people like Julie or Lori or Ted or. Looks like Tina has a question.
I'm not sure if you'd be able to answer this, but I'm wondering, in the community, for people who are interested in ketamine and they're going to pay out of pocket for this, there are some clinics who will use it for mood, but if you've got pain, you're excluded, and vice versa. Is that because they're doing studies, or like what's the rationale behind excluding a population for which it may help more than one issue?
Yeah, so that's a great question, Tina, because obviously the reason that I work at the clinic I do is because I have an interest in chronic pain, and because it was an avenue that I saw as being the stepping stone to get to public funding for it. But a lot of the other clinics, I think the concern is there isn't a great body of literature. Like the literature for a mood disorder is actually quite large and rapidly expanding, right? And it's been a focus for ketamine for probably going back a decade now. And the pain world, the pain literature is not great. It's limited studies, limited numbers. It's just been a very difficult to study topic. So I think that a lot of those other clinics, they're a little bit anxious about offering it to people with pain as their primary diagnosis. I will have to say that a lot of people that I've seen come with dual diagnosis. So a lot of people, I would say probably 75% of people coming as a mood disorder referral also have a concomitant pain disorder. And I've seen things that I've never even seen at the pain center. I'm like erythromelalgia and like, it's been interesting and eye-opening for me as well.
Thanks so much, you guys. Really appreciate it. Yeah, the literature for mental health is increasingly robust for sure.